A 57-year-old woman is brought to the office by her husband for a postoperative visit 2 weeks after undergoing a total abdominal hysterectomy and bilateral salpingo-oophorectomy for leiomyomata uteri. She was discharged 6 days later after a 3-day course of levofloxacin and clindamycin for a vaginal cuff cellulitis. However, since discharge, she has had fever, increasing weakness, and lower abdominal pain. She has had 6 to 7 episodes of diarrhea daily. She appears mildly uncomfortable. Vital signs are temperature 38.2, pulse 92 per minute, respirations 14 per minute, blood pressure 132/80. Physical exam discloses diffuse abdominal tenderness. Tests of the stool for occult blood is positive. What is the most appropriate initial pharmacotherapy? So students will ask you to put your answers into the chat. Let's ask the students, as you wrote your answers and you read this, what were you thinking? If we could hear from a couple of you, that'd be great.
So seeing that this patient was recently hospitalized and was on a course of clindamycin for 6 days or for 3 days, I was thinking of C. diff, and given her symptoms with a low-grade fever and copious diarrhea, I thought oral vanco was the best answer.
Yeah, I think that's good intuition. Certainly makes you concerned for something based on the time course.
I was thinking with the fever and the diarrhea and the occult blood positive, I was thinking more of a colitis picture and C. diff in particular after a long hospitalization. So I ended up picking bank as well. Great.
So here are the things that we felt were important. As red flags as they were to this case.
So this is a 57-year-old woman who's coming for a post-op visit. She's 2 weeks post-op, and so one of the things that catches my eye in this case or with this patient is that she has a very common procedure, and she had a prolonged hospitalization. So that to me equals a problem, and we're told that she had a cellulitis, a vaginal cuff cellulitis, and was treated in the hospital for that. But she's not getting better. When people have surgery, whether it's pain or just generally feeling better, that should be improving with time. And this is not with her. So that's obviously a red flag in this case. She has a fever. Her other vital signs are okay. And she has abdominal tenderness. All things 2 weeks post-op that you probably shouldn't have. And then, the thought is an infectious etiology, given the fever and the post-op nature of her complaint. So obviously thinking about with the diarrhea, some form of colitis or something along those lines, but you still have to think about a wound infection, whether that's a superficial external cellulitis or a deeper wound, perhaps even an abscess in her abdominal cavity or pelvis.
So let's now give you an option set to choose from. Which of the following is the most appropriate initial pharmacotherapy? A, cefoxitin IV. B, diphenoxylate with atropine or Lomotil orally. C, metronidazole orally. Or D, vancomycin intravenously. And E, vancomycin orally. So let's see how you did. And Dr. Rebbecchi, take it away.
Is this patient too sick to have, kind of oral therapy or to go home? And it kind of leads me kind of into the question and the pertinent information that we have given you in that question. So this is a colitis or an infection likely caused by the antibiotics. So the intravenous options here, given this patient who's moderately ill and there's no indication likely to hospitalize them, would probably come off the list. Choice B here, which is for symptomatic relief. And it would really come down to between C and E.
So let's dive a little deeper here and hear from the students. What was your approach to this? And when you think about big picture, how sick this person is, how sick they might not be, what were you thinking as you made your choice here? Which was the correct choice? Savannah, go ahead.
Yeah, so I think I was happy. I try to, when I read the vignette, have an idea of what I want to see in the answer choices before I look at them. So somewhat reaffirming to see oral vancomycin as an option set there. But having the question set makes me think is, have I ruled out by reading this question that this is some sort of like more complicated infection from her vaginal cuff cellulitis? Is this some sort of like a bizarre diarrheal infectious illness? And I feel like from reading it, that wasn't the sense I got. I honed in on the 6 to 7 episodes as well and felt like that was profuse enough to be consistent with C. diff. And like you guys, I think I looked at the vital signs and just scanning those, none of those stood out to me as we were talking about as being something that I'd say, whoa, this is really bad. This person needs to stay and probably can't tolerate orals.
Yeah, those are great points. Anyone else?
Another thing that I like to do, as long as I'm okay on timing, is look at the other answers and sort of convince myself that the other answers are wrong and that my answer is still the best choice. So in looking at the low-grade temperature and the occult blood positive, I was able to also strike out answer B, not wanting to stop the diarrhea and to treat orally.
Many of the items you see on NBME exams, there's not going to be necessarily one completely wrong answer or even 4 of them. But the idea being that you're going to have to discriminate and dissect the information so you can get to the most correct answer. And you can imagine on some questions that you've seen in the past, that can be a task. Sometimes students will say, I could get it down to A and B, but then I really had to go backwards and look at the information again. So that's a great approach. Any other thoughts?
Yeah, when I originally saw the question without the answer choices, I was still thinking maybe she might need some type of reoperation, seeing the occult blood being positive. But after then checking the vitals again and thinking she's probably not septic, she's not having like a surgical abdomen, then probably oral antibiotics were the better option.
Yeah, a great point. We would expect the generalist physician to know when to call a surgeon for sure. Things we don't have here, like whether or not there's a white count above 15,000 or whether or not there's renal insufficiency, 2 big things that might sway Dr. Rebbecchi and those of you going into emergency medicine into admitting this patient to the hospital. This question in its original form had C as the right answer. And that might give you a bit of a history lesson that when this was originally written was probably close to 10 years ago. And since then, the guidelines have changed. And this is sometimes something we have to deal with as we're creating the content for the exams and making sure that they're fair, is also keeping up as medicine changes. And this is certainly one of those things. The other thing that's changed since then is that thank goodness this didn't have the name of the bug in this item, because since then it's been changed from Clostridium to Clostriroides, and so that could pose a problem as these items end up on certain exams. So